when you talk about things from your past, and when I talk about things from my past that are difficult or upsetting, we don't fully re-experience the event. We can talk about it as a story, right? And so for people that don't develop PTSD, they develop that ability to talk about what happened. I went here, this happened, this happened, this happened. And then their mind and body all of a sudden don't go back into fully experiencing it.
Welcome. This is a jam-packed 42-minute podcast on one of the most requested topics that we get, which is PTSD. The episode will primarily be relevant to healthcare providers and people who use drugs. In previous episodes, we covered trauma-informed care and seeking safety, which is an evidence-based treatment for PTSD and substance use. Here, we talk about trauma and substance use, the self-medication hypothesis, and why it became important for Dr. Whip to offer treatment for PTSD, how he learned the skill, and the menu of treatment options for PTSD, CPT, and how it works, and the value and importance of hope. For individuals with PTSD, of course, they can learn about these therapies in the hopes that they will reach out to their healthcare providers to find out which therapy is a good fit for them. Thank you, and I hope you enjoy.
So my name is Whip Lamba. I'm a psychiatrist who mainly works with people who use drugs. I do that in a hospital setting. And I sometimes do a little bit of trauma therapy and trauma counseling.
Okay. And I'm Jean-Paul Michael, and I am a community caseworker, and I work for an inner city hospital in Toronto.
Okay. So today we're going to talk about post-traumatic stress disorder, and we're going to talk about a treatment that I believe in, right? Treatment that I believe in, treatment that I've been trained in. I'm not great at it, but I think I'm good enough. And what we're going to cover is why it became important for me to learn a specific therapy for PTSD specifically, and I picked this one out of a few options. We're going to talk about how I learned it and the community around me that I created to try to make sure I follow through and pick up the skill set. And we're also going to talk about some of the specific elements to it, almost so that we can give our audience and each other almost a taste of what this therapy is, what it could be, all that kind of stuff. And then we're going to make sure that we have a framework that we can use this therapy for people who use drugs.
Yeah, and I'm so excited that we're covering this topic because it's something that I think it's kind of the in the different skills that certainly I have as a caseworker. I think it's the one that's probably the weakest and the one that's most needed. Because we have so many folks that have had such a difficult life by the time we see them, right? Such a challenging life for just the laundry list of reasons just would go on for days, and anything that we can kind of touch on that would help kind of sharpen our tools or give us any tools, it would be so valuable, and I think we lack it so much, unfortunately, and it's always something that. When we're doing counseling and we're doing casework, we stumble onto it invariably, and I just feel like anything I could get on this, I'd love to have. So I'm a sponge today. So
and for your day-to-day clinical work, the seeking safety and a further deeper dive into the content actually would cover all that you need to know as a caseworker, case manager, who works with people who use drugs and who works with people that have trauma. I really believe that philosophy of care, that manual, that treatment really gives us all the day-to-day school tools that we need to work with people. The value that this is going to add to your life, I believe, is that when you're working with patients that have some kind of trauma, if you know what the destination is, like what that PTSD treatment would finally be if they were to go through it, you're going to believe in it, and then you're going to see that hope, right? If you're seeing a patient who's never trusted anyone because everyone they know has hurt them, if you're seeing somebody who responds with anger anytime they're put in a position where they don't have control, by you knowing the potential destination for that, it's going to put you in a place that you'll have more hope and you can even guide them through. Right. It's almost like when we used to have talks on medication, right? We would chat about it, and I would say, no, there's so much value in you knowing about the risks and benefits of buprenorphine. right? Like knowing the risks and benefits of methadone, knowing how it's done. Because if you're the one who's working with the person, you're seeing them at the detox, you're seeing them daily for 4 days, they're going to trust you, and you can actually share those risks and benefits and prep them for what the doctor encounter is like.
100%, yeah.
So for this talk today, it's really is around post-traumatic stress disorder treatment. And as you may remember from our last talk on seeking safety, I was running a group for about 2 years at least, right? The first year I felt we were just sort of building up our chops and that skill set and sort of getting feedback with our community practice. And then we were running for that second year as well. And then a couple of my co-facilitators came to me and they said there's a couple of people that they would see individually, because when we started it, that's how we set it up. We set it up that you could come to the group, you had to have the one person you were connected with individually, just so we could catch if anything happened, right? Because we don't want people to fall off. We don't want people to relapse or at least not see somebody and disappear and relapse, and then we don't know when we'll see them again. So people were saying we want more, right? Because what does Seeking Safety do? Seeking Safety talks about the headlines of the trauma. It gives you skills to function on a day-to-day basis. It gives you specific tools you can use. Say if you're the kind of person that avoids conflict or that doesn't set boundaries, it'll help you fine-tune those. It helps you look at yourself with more self-compassion. And it also makes a very, very strong emphasis, which is very relevant to your work, on how do you connect to all of the relevant community resources. And for you, when you're working in a detox setting, you don't have the ability to be everything to everyone forever, right? Well, nobody does, but you do have that ability to figure out what this person's needs are and connect them to relevant resources. So the two friends that I had, Chris and Tony, were talking a lot about patients that really wanted more. They're like, look, Whip, they've done this stuff. And around that time, I came across the 60 Minutes episode. It was about 10-15 minutes long. It was a segment. And we'll include the link in the comments as well. And it was talking about cognitive processing therapy. And they did a study with veterans, right? So in the States, they have all these VA hospitals.
Mm-hmm.
And they get very good medical care there and very good treatment there, at least from what I've seen in terms of the models. And so they were offering this trauma treatment. They were offering it for people that had a history of alcoholism. They studied it and published the results. And what they found was that 50 to 70% of people that completed the treatment were better after 8 to 12 sessions. And that's shocking, right?
Now, did better impact their substance use? What was the definition of better?
Better was for their PTSD symptoms.
Okay.
So their alcohol use, I have to go into the papers later on, their alcohol use wasn't as severe as some of the patients that we see.
Right.
But from her and from a couple of colleagues, it was very clear that the substance use was more pervasive and long-term and chronic than it was the PTSD, because once people went through the PTSD treatment, those symptoms weren't affecting them anymore.
So just, sorry to interrupt, but are we, this concept of self-medicating for your PTSD, what's with that?
Yeah, I think I just hear people that fully believe in it, and I hear people that are completely against it. A lot of psychiatrists I've talked to, when they look at the literature, they say, hey, I don't believe it in any way. From my end, I just listen to the person's story. If they believe they're self-medicating for it, I'll try to figure out, well, what are the specific symptoms they're self-medicating? What are ways that they can get those same relief, without the substances, with something else? For the people that don't believe in the self-medication hypothesis, that's fine too, right? Because I try to use that lens as well. I really believe in dialectics, and I'm not going to deny somebody's truth unless I think it's harmful.
But is it a fact that people that use or people that have a history of trauma, use substances more than people that don't?
Yeah, that's a fact. So definitely correlated, right? So if you have a history of trauma, you're more likely to use substances. If you have a history of trauma, you're more likely to get addicted to opiates than if you don't have a trauma. But it's not like an all or none thing. There's certain people where their brains are wired a certain way, where when they get that first Percocet from the the dentist, they get such relief from it that that they just they don't have anywhere else in their life to get it. And especially, I think, if you've had sexual trauma, the risk of getting addicted to opiates is much, much higher. Alcoholism, I think so too, but there's also a very, very strong genetic component. So if you have grandmother's parents that are had severe alcohol addiction, whether you're adopted or not, you're going to be more likely to develop it as well.
Yeah, and sorry, and not to dwell on it, but if it's an actual correlated fact that people with trauma are more likely to have a substance use problem
Than the general public.
Yes,
public. Absolutely.
Yeah. Then isn't that self-medicated? Doesn't that sort of meet the threshold of your self-medicated argument in some way?
I don't know. So all I know is that I've been to numerous teaching sessions throughout and you get these people that are very skilled, very trained, very scientific, and they say with such certainty that it doesn't exist. And then you go to other sessions where people believe it fully and truly and deeply. And I really think, when you have something that brings such strong beliefs in people, there's got to be some hidden kernel of truth or a subset of people that it helps, right? So I'll give you an example for this, right? So the whole idea between compassion and having rigid rules. I think there's certain patients and certain friends and certain family members where they need the compassion, and other people where they need those rigid rules, right? And you have to figure out what to use and when. And so, I mean, for me, whether it's self-medication or not, what I care more about is what's the suffering the person is going through and what's going to help them get better. And if defining it as self-medication or defining it as not self-medication is going to help me help the person get better, then I'll probably dive deeper into it.
So, yeah, and I mean, and again, sorry to dwell, but I'm just,
No, I think we have to go with what you're curious about, right? Because if the foundation doesn't make sense.
Yeah. So I think there are, so many individuals that I see in my work setting that have just an insurmountable amount of traumatic events that have happened to them in their life and that continue to happen to them in a way. And, and I've been across the table from them and just hearing the desperation, like, why would I even stop? Like, kind of that.
Why would I stop using substances?
Yeah. Why? Because then I'm going to have to think about, my dire health situation. I'm going to have to think about the fact that my family doesn't talk to me anymore. I'm going to have to think about what happened to me when I was 8 years old. And I think maybe we've gotten ahead of ourselves as far as the definition of trauma, but I mean, these traumatic events just keep happening, right?
Yeah.
And it's just, and it's a little bit of a self-fulfilling prophecy in a way, because the substance use is making a lot of these events happen in a way, right? Because
absolutely, yeah. Yeah, and so I didn't talk about it now, and you know what, I didn't even talk about it in the seeking safety talk, but when you go to the seeking safety sessions, so when they talk about these concurrent disorders, when people have mental illness and a substance use disorder, they'll talk about the two-way relationship, right? So sometimes the mental illness can make you more likely to use substances, sometimes the substances can make you more likely to have the mental illness symptoms, and trauma works that way as well. And we've seen people where they have an incident traumatic event and the substance use follows. We've seen people that start to use substances, and then through the substance use they've had these situations that are very, very traumatic. And the case that you're talking about, I think that makes this therapy that much more relevant for you to learn about, at least theoretically, what it is and how it could help, because you're describing somebody who has a lot of difficulty being in their skin.
Yes.
And the substances are the only way that makes it palatable in any kind of way.
Absolutely.
And I don't know if you've ever seen that movie Basketball Diaries with Leonardo DiCaprio. I don't know when it was released, maybe the 80s, 90s. I don't know when it was released. But there was one scene in there that was just so powerful. And it was a scene where he was screaming and yelling and crying and some kind of thing. And they contrasted that with the relief that he gets when he uses heroin. And it was just this immense peace, right? And it's foolish to think that if we don't help people believe that they could eventually experience some kind of peace, that they would ever choose something else. And so for me, knowing about the PTSD treatment gives me hope that these people that we see where they're just so scared of facing the trauma, they'll build the skill set that they can lean in a way that's healthy. Because what happens for a lot of them is that when they don't have the basic skills, so say they don't have the basic grounding skills, they don't have the skills that are covered in seeking safety, If they don't believe, there can be a therapy that makes them look at the world differently. When they lean in, what ends up happening is they end up re-experiencing the traumatic event, and it can continue for sometimes a few minutes, a few hours, a few days. And I still remember one person that I talked to where I was like, hey, why don't you go for nature? Why don't you go have a walk? I thought it was a great suggestion, just to get him out of the comfort zone. And when I met with him the following week, he pretty much went to the park, got a chair, and just enjoyed he started dissociating for 4 hours. He was like, it was horrible. All the past stuff came back. And so with these people that we work with, I think, believing in that, getting them a proper diagnosis, giving them a menu of treatment options, helping them connect to it, and knowing what the end game is, I think we can do a lot for them. They say in the war times, you want your most experienced surgeon at the front. And the reason is because if you know what the destination is, you can tell almost right away when you see someone. And when I started working as a psychiatrist, I could diagnose someone with PTSD. I could give them the medications or recommend the medications. I could refer them to the therapy programs. But I didn't really know the destination for it. And this therapy gives me a clue about what the destination for PTSD can be.
So it kind of sounds like the substances, for them, that is their tool.
Yeah, and in this
one
therapy,
of their tools.
yeah, that's absolutely it.
And now it's about is it a matter of, and I'll let you get into talking about the tools, but is it a matter about giving them alternate tools? Is that a
yeah,
way of
that's
saying
part
it
of
too?
it, right? So this is a great segue in terms of what sort of happens with that PTSD experience, right? And so with traumatic events, not everyone develops PTSD. And so what happens for people that don't develop PTSD, you can almost think of it like a ball. And I'll see if I can, and so you have these the traumatic event, then you have the intrusions for it, like the memories, the thoughts, all that stuff related to it. You have the physical sensations for it, and then you have the narrative, right? And so when a traumatic event happens, all that stuff is linked. So the physical sensation can bring out the narrative, that can bring out the emotions, can bring out the thoughts. All that stuff is linked. And early on, what ends up happening is that you end up fully experiencing it, right? So like the fire situation we talked about earlier, where like say something's burning down, you might feel like, oh my God, the place is burning down. So what happens for people that don't develop PTSD, right? And I mean, I shouldn't be judging or whatever, but I think for you, this is for you, because when you talk about things from your past, and when I talk about things from my past that are difficult or upsetting, we don't fully re-experience the event. We can talk about it as a story, right? And so for people that don't develop PTSD, they develop that ability to talk about what happened. I went here, this happened, this happened, this happened. And then their mind and body all of a sudden don't go back into fully experiencing it. So for the people that develop PTSD, you're talking 3 months, 6 months, a year after those events. If they see a color that reminds them of the event, if they hear a voice, if all of a sudden they're in a position where they don't have control or power and someone's telling them what to do, their mind and body might start reacting like they're having the event. And so how they deal with it, they deal with avoiding it, right? They deal with avoiding it because that's the only thing, and they could avoid it with substances. They could avoid it with self-harm. They could avoid it with getting into unhealthy relationships, escaping. They could avoid it with partying. They could avoid it maybe with diving deep into work, which might be a good thing, which might not be a good thing. I don't know. But all these things are avoidance behaviors, right? And so a core component of this psychotherapy that I'm going to talk about today, which is cognitive processing therapy, which is one of the 3 evidence-based treatments for PTSD, is that these avoidance behaviors don't have to happen anymore because you learn when and how to lean into whatever uncomfortable emotion there is.
Yeah. Okay.
So
you're going to tell us about it?
Yeah. So what have I talked about so far? So we did the seeking safety groups,
yes,
where I believe they were going well,
yeah,
for what they were, and but some people wanted more trauma treatment,
right,
and we still had trouble.
And that was for the folks that wanted to circle back and I think we said finally deal with it, or maybe not finally, but deal with it.
Well,
do
they're
the
just saying,
deeper
hey, this
dive.
is great. I like coming to these seeking safety, and for the men, we called it seeking strength. Actually,
Yep.
we called them seeking strength or power. We sometimes would have them come up with their own names for the group, and so they were coming regularly. They were getting something out of the experience, but they would say, like, oh, Dr. Lamba or whoever, this is not enough. I need more. I want to work through this stuff. I'm tired of these patterns I keep getting into, and I'd like to deal with it a little bit better. And then back then, in terms of evidence-based treatments for post-traumatic stress disorder, usually in most guidelines, they would give 3, right? So the 3 that they would give, one would be EMDR, which is the eye movement desensitization.
Mm-hmm.
The second one would be CBT with prolonged exposure therapy. And then the third one would be cognitive processing therapy. And I didn't feel comfortable doing EMDR, the eye movement one. So the EMDR is like this thing where you move your eyes, you visualize something, you move your eyes, you visualize something. And for a certain subset of patients, there's this magic that happens where all of a sudden that autobiographical narrative separates from that physiological experience. So for people with PTSD, when they're like any kind of trigger that happens on the news, on TV, in their environment, their whole body responds like the trauma is happening again. For EMDR, some people going through that process separates the two. The reason I didn't feel comfortable going there is that with EMDR, there's a certain level of dissociation. And for people that we work with that use substances, I feel it's almost more common. I mean, I'd have to look up the data to see that. And dissociation is something that I'm still trying to get comfort with. And I'm not able to give people a good experience unless I can get them into like an intensive DBT and seeking safety and those kinds of skill-based programs.
Okay.
So I didn't pick EMDR. I didn't pick prolonged exposure, and a good mentor and a colleague of mine used to tell me that when she was doing comprehensive PTSD assessments, if she did them in the afternoon or evening, she would actually start to get nightmares. So she had to actually do it in the morning. And with prolonged exposure, you help somebody come up with that narrative.
This is for her as the therapist, not
as the
not the
therapist.
patient.
Yeah, sorry. This is for her as a therapist. And for the patient who's doing the cognitive behavior therapy with prolonged exposure, they sometimes have to write it out or record the traumatic event, and then they listen to it and listen to it and listen to it again. And then they do that to the point where their body does not have that physiological response.
Wow. Okay.
And from a selfish perspective, I felt that would be too much for me. And with the cognitive processing therapy, when you start to look at it, because that's why there's all these examples of phenomenal scientists and psychologists that do phenomenal research. There's something about their PhD training that makes them very, very good at it. It doesn't matter whether it's Robert Myers, Lisa Habits, Marsha Linehan, or Candace Monson, who developed the cognitive processing therapy. They work as scientists, so they'll always be adjusting and adapting components. And when they first did cognitive processing therapy, you actually had to come up with a full written narrative of the event. But lucky for us as society, they also studied it without doing the written account. And people do just as well without doing the written account. And so I don't know if it's selfish from my end, where I just, I want to make sure that I can keep serving as many patients as possible. But when I saw the data that said that if you don't do the written account, you can actually get as good results, I'm like, I can't not offer this therapy. And so now this therapy is offered everywhere, that partially because of COVID, and otherwise you can do this online training. You can do it for minimal prices. There's one place, one website, university website, that offers a bunch of the training for free as well. And so after I saw this video, I started emailing Dr. Monson. I emailed her like probably monthly for like 3-4 months. It's like, hey, when's your next training? When's your next training? And then finally she's like, look, if you can get 20 people to attend, I'll be able to run a training for you, right? I'll be able to run the 2-day training for you. It might have been 2 half days. I can't remember. And so what I did was I started emailing a bunch of my psychiatry colleagues, right? Because psychiatrists make a bit more than case managers. And I'm like, okay, if they go, they'll be able to sort of pay for it in some way. And then I cover the cost, about 4 or 5 case managers to attend as well for this 2-day training. And so she did this 2-day training. And then the other thing that I had to make sure, so when you're learning a new skill, you need some kind of a mentor. What I believe you need some kind of mentor or guide. You need like basic content knowledge, and then you need to practice long-term with feedback. And also before all that, you need a reason why it's important. That's why I said why it's important first. And so we did the 2-day training. I convinced, I don't want to say I convinced, I'm sure they want to. I convinced 3 or 4 docs that I work with to get supervision. And so we all got 2 or 3 cases. And we met with one of her former postdoc students almost weekly to go over it. We did that for about I don't know if we did 10 sessions or 12 sessions, but after going through that supervision, I felt like I got a grips of it individually. And then I got really lucky that they had a national study going on for it. And so then I rolled out a group for that therapy. I tried to include people that mainly used drugs. And then we got supervision that way through it. Although I think if I had to do it again, I probably would have made sure I had a teammate in the group. And then I also, in agreeing to the study, because it was around, the study started pre-COVID.
Yep.
And then the study finished after COVID. And that was around the time that I shifted hospitals. I did not have the same environment, the same time, the same resources, and it was very difficult for me to do all those things in the context of COVID, shifting hospitals, shifting from in-person to online, virtual group, and those kinds of things. It became very, very challenging.
So that's how you got the skill set of cognitive processing therapy.
Absolutely. And so the therapy is very interestingly designed. And so I don't know how familiar you are with cognitive behavior therapy, but with cognitive behavior therapy, it's all about how your thoughts link to your behaviors, that link to your emotions, and all this stuff occur in the environment. And some people, what they do, they'll add an extra box around physical sensations. And so with cognitive processing therapy, you may have something like, for example, when you go to the store and you go to well, you don't drink coffee, but if you did drink coffee and you went to Starbucks and the person was rude to you,
sure,
you may have these thoughts like, oh, they're judging me, or I'm not good enough, or whatever it might be, and then you might get upset and angry and yell at them in some kind of way, like,
sure,
why are you being why'd you let that person go first? Why'd you prepare their coffee first? Whatever that might be. And so with cognitive behavior therapy, you start to learn what are some of the beliefs behind that, right? So you might have this belief that I'm not good enough, or I'm not lovable, or everybody hates me, or people judge me, whatever that might be, or they think I'm an addict, or whatever that might be. And then you train your mind, and you do it through writing, right? Because it's a different kind of mental muscle. You train it through writing to go through these thoughts and beliefs, why you might have them. You go to evidence for, evidence against. So if you say the main thought is that people judge me and think I'm an addict, right? You'd go through what's all the evidence for, but then you also have to go through all the evidence against. Well, I've got this job here, patients like me, my boss trusts me with things, whatever that might be, and then you come up with this new thought. And eventually, when you go through that, you can get to some of the deep stuff. You can bring the stuff in your past. There's all these creative ways to do cognitive behavior therapy. But the reason cognitive processing therapy is so good for post-traumatic stress disorder, it goes right to the meat. So when I have a traumatic event that happens to me, or when somebody has a traumatic event, it completely changes how they look at themselves in the world. So if you're I don't know, walking home at night and you're assaulted one evening. It could be a physical assault, it could be with a gun, it could be whatever it is in that kind of way, right? You start to have these beliefs about yourself in the world. You might have these beliefs that I can't trust my own judgment. Like, why was I walking late at night? You might start to blame yourself for things. You might believe that you deserve bad things to happen to you. And then what happens is that when you have these beliefs about the world not being safe, or if I go out at night, someone's going to harm me, or I can't trust anyone, or all men or all women are evil, whatever it might be, it permeates to every area of your life.
So in that example, if we just want to drill down on that for a little bit, so that me being robbed by didn't happen, but if I walked down the street and I got 2:00 in the morning for whatever reason, and I went to get ice cream, and I got robbed with a gun. So in that scenario, would that be my traumatic event? I mean,
okay. that and it all depends on how it affects you, right?
Right.
So,
but it affected me in the way that it manifested itself in the way that you just suggested, which is where I blame myself. Then I have trouble maybe walking, going out for a walk anymore because I think, oh, bad things are going to happen to me, and I'm stuck on that, right? I'm just stuck.
Absolutely.
I'm stuck on that. So in that, I know a very limited example, and I'm not asking you to diagnose me, but you could say that that me being robbed on the street was traumatic, the after stuff that I'm dealing with. I don't want to leave my house. I don't want to do this. It is as a result of that.
Yeah, it could be. And sometimes you have to tease it out, right? Maybe you're always a cautious person, right? Maybe you're always sort of careful. Maybe your level of comfort with risk is different, right? So you have to tease out, is this actually the traumatic event that's causing it, or is it more just how you are in general, right? And then the other thing we'd have to figure out whether or not to go through the PTSD treatment is, have the symptoms stayed with you? So, for example, like if you have some kind of a trigger or reminder, does your body feel like it's re-experiencing it? Do you have like nightmares or flashbacks about it? Do these beliefs, did they change, right? So in cognitive processing therapy, there's probably two ways that it can happen. So one is that, so you have an amazing life beforehand. Your life is phenomenal, right? Like your mother loves you, your father inspires you, whatever generic stereotype leads to the perfect life, which I don't know what it is, but imagine you have that. And you have these beliefs of the world that are somewhat realistic. So you could have a traumatic event, and the traumatic event just flips everything all around. So you went from thinking people are genuinely good to nobody can be trusted. I can trust my own judgment to like, I always make mistakes, whatever it might be. The other thing that can happen to people is that, say if your life was just horrible, like your life was just bad thing, bad thing, bad thing. You already have some of these beliefs, like I'm not to be trusted, you can't trust people, whatever it may be. Then those beliefs cement in, and then they happen and affect you in every single area. And so what cognitive processing therapy does, it goes to the core belief. So the example at the Starbucks, right, or the coffee place, it could have been just that one event. It could be like a mild depression where you question yourself, but it could also have been because of a trauma. Right? It could have been because you had some event where people treated you horribly, and then you were like whatever, like assaulted or something, and then all of a sudden all your other events are. So if you did it through the regular cognitive behavior therapy process, you have to do like 3 different events. You have to do that. You have to go through the past, all that kind of stuff. It might take forever to get to the meat. But if you do cognitive behavior therapy, it doesn't really cognitive processing therapy. And I get it mixed up because technically cognitive processing therapy is a type of cognitive behavior therapy. It's just so strategic.
Okay.
And it goes right to the meat of the incident event. And when you go to the incident event and come up with a more realistic version, all of the other stuff follows. So for example, for the example that you gave, I would say if I went for coffee or ice cream at 2 a.m., like a reasonable response you'd have for me is like, well, why would I want to go for coffee at 2 a.m. anymore? Why would I want to go for ice cream at 2 a.m. anymore? But what happens for people with PTSD is they don't have an accurate version of the risk. So, for example, if you've been in a car accident, you might believe every time I get in the car, I'm going to be in an accident. Every time I go out at night, I'm going to be this. Every time. And for me, I think just because everyone has different risk levels, the goal of the therapy wouldn't be that you go for coffee at 2 a.m. and it's fine, unless it was something where you worked at a coffee shop or you worked there and you had to go to work and that's the only job. Like the goal would be that you have an accurate assessment of what the risk is based on your other experiences. So for example, if you'd been to ice cream at 2 a.m. 100 times and one time you were assaulted, like you don't want to have the belief that every time you go there, you're going to be assaulted. You would want to have that belief that, well, 1 in 100 times I was, maybe it was like some kind of a festival weekend or something. I don't know. And you just want an accurate version of the risk. And then you can make that decision about whether you go or not. Because when you have trauma, it's like all or none thinking. It's like everything sort of takes over.
And I guess, so is it fair to say that once you've successfully completed this, you're able to put that event in perspective? Yeah,
and it does it by going directly at the thoughts. And it does it in a very, very creative way. Because when the case that you talked about earlier where the person is like, I just don't want to deal with my memories, I don't want to deal with my past, I don't deal with any of that stuff, the challenge is people don't know when to lean in. And so another important concept that comes up in the therapy is a primary versus secondary emotion. And it's a little bit complicated, it's a little bit nuanced, and I'm still sort of trying to get it fully. But when you think about, say, if you were abused or hurt or harmed or assaulted as a child, what would be a normal response? Normal response could be fear, right? That would be normal fear. It could be anger. Guilt would not be a response. That would be a primary emotion. That would be a secondary emotion, because in order to have guilt, you have to have certain kind of thoughts and judgments associated with it. I should have done this. I could have done that. Why didn't I do that? But the fear is absolutely a primal, or sadness. Sadness would be a primal response, right? And so the way that Dr. Monson and Resnick do it in the cognitive processing therapy, if you're experiencing a primary emotion, that's when it's okay to lean in. And the metaphor that they use is a fire, right? And so say if there was an event that occurred where it would be normal for anyone to feel fear or anyone to feel sadness, if that's the emotion that I feel, it's okay to feel it, because the log is going to burn out, right? So say if you have a fireplace, you're burning that fear, you're burning that sadness, is actually going to burn out. But if it's a secondary emotion, if it's guilt, and sometimes anger can be a secondary emotion too. Anger is a bit complicated. So if it's the guilt that's there, and you're feeling it, you're going to burn that thing forever, because it's like pouring kerosene on it. So some of these people, they haven't heard of primary or secondary emotion, and instead of feeling the sadness, they feel the guilt. And the guilt, you could be guilty in your head for years, right? Like you can go in circle for years. And so that's where this becomes so powerful, because it helps balance out that it's not a fun therapy. It's really, I was going to say the F word. It's really effing hard.
Yeah.
It's really, really effing hard. But once people go through that process, it's almost like this domino effect, right? Where once they start to believe that all men aren't evil, right? Like I've had a couple of men that were, or all women aren't or evil, or sometimes I can go out safely at night. Sometimes I can leave my door unlocked and no one's going to break it, right? Like once you start to get a chip, right, in that belief system, sometimes the rest of all, and it does it very strategically. So the same way that, say, if you were like, I don't know, learning how to play basketball, right? You might learn the basic rules. You might learn how to do a chest pass. You might learn how to do a jump shot. You might learn how to shoot a free throw. You might sort of learn different plays. So what it does is the first few sessions teach you the core basic skills. And then by session 6 to 7, you put it all together, right? And so say if you have an event where you're either emotional in some way, like your anger, but the anger is higher than what you would have had before the trauma or what somebody else would see as reasonable. You learn the steps and strategies on how to analyze that, break that down, and come up with a more accurate statement about what the actual risk is.
Yeah. Okay. That makes
Does that make sense?
Yeah, that makes sense. So I guess that's where the skill gets in. That's where the skilled, I guess, therapist or clinician being there to sort of guide you through what is the primary versus secondary emotion to lean into, because it may not be intuitive.
Yeah. And the primary secondary is, it's important, right? But it's still a very cognitive therapy. So it spends a lot of time going at the facts and the details around it, right? So, but you have to eventually do that, because it's because that's how you separate the autobiographical narrative from the physiological response, is that you have to allow the primary emotions to burn out, and then for the secondary emotions, you have to unpack it so you can find the primary emotion under it and allow it to burn out.
Okay. And where do people generally get this therapy? Which?
Yeah, so we're in a really lucky time in Ontario, and I'll tell you that right now, because they have the Ontario Structured Psychotherapy program.
Okay.
And when I was working at Ontario Shores, which I did for about 2-3 years, I really loved being there for a couple of reasons. So say if I do my initial assessment and I can diagnose somebody with borderline personality disorder and or PTSD, I can refer them to the dialectical behavior therapy program first, right? And I'll explain in another session why I would refer them to that first if they had both. And then once they're done that, I can refer them to the cognitive processing therapy program there. And so the wait list is absurd, right? I think right now it's like a year and a half, 2 years for the trauma program. It's maybe a year, 6 months for the DBT. Like the wait list, but at least there's something, right? As opposed to this like black box that was like when I graduated, where I didn't know where to send them. Candace Monson does have her own clinic. It's covered by insurance. So if you have insurance, you can have it covered. And most so the thing to remember, the reason why I talked about seeking safety first is because for this therapy, at least when I've done it clinically or colleagues have done it, the dropout rate is pretty high. 20 to 40% of the studies, most individuals, CPT practitioners will say about 50% is the dropout rate. I don't know if that's true or not true. I may just be sharing personal anecdotes. But the seeking safety is great for the people that drop out, but the people that stick with it, right? So for those, whatever percentage stick with it, about 50 to 70%, depending on the study, their PTSD symptoms are almost gone by session 8 or 9, or by the 12th session. Like we'll have to get the actual data, but can you imagine like these people that we work with where they've had trauma symptoms that shaped their life for decades? And then there's this therapy they've never been exposed to. And so the reason that I love working with people who use drugs is because they normally don't get access to these therapies, right? And by us becoming so good at working with people who use drugs, at knowing what that long-term treatment is, we can create a space where they may believe it's possible. And there's pathways even covered in Ontario. Like the province that we like, we're a have province compared to some of the other ones, you know?
Yeah, absolutely.
Like it's just like, when we talked about where we used to work, and I was just sharing that, I wish we had more support. You're like, they had a lot more support before, right? Like, and so I think like, we're in a lucky time that there's this Ontario structured psychotherapy. I think we have to help people figure out how to navigate it, right?
Sure.
Because for some people it's going to help, and some people it's like I just think there's some nuances that the average person and the average healthcare provider and the average case manager wouldn't know who to send, who, where, for what, and when.
Absolutely.
And I think these sessions can really help us figure that out and help our colleagues figure it out. And it's a constant iterative process, right? Because as you sort of saw with my journey from when I graduated to where I learned dialectical behavior therapy, to where I learned CRA, to where I learned craft, to where I learned seeking safety, to where I learned cognitive processing therapy, to where I learned harm reduction, like there's more and more information coming out.
Yes.
There's so much information hidden in the literature that hasn't spread to the masses. And by increasing this awareness, we can have more hope in working with the patient in front of us, and they're going to feel that energy, right? Because when we have that hope, it's contagious.
100%.
Right?
Yeah. Hope is contagious. I like that. I like that.
All right. Thank you for listening, man. This is just it's one of those things when you see it, you can't unsee it. And I hope for you that now that you're not going to be able to unsee it, we can start to figure out which patients would eventually benefit from that and how to get them in a state so that in 1 year, 2 years, 5 years, they can go through this process.
Yeah, 100%. I mean, I can't, it's almost the list of, of individuals I see on a regular basis that haven't had some exposure to, first of all, almost none of them have had the exposure to the treatment, but almost all of them have had it, are suffering with this, right? And suffering in isolation, and it's so I like the fact that that there's hope, even if they can't perhaps navigate the actual specifics right now because of other things that are impacting their life. Maybe they're homeless, maybe they're this, maybe they're that, but I think just the fact of having hope can be so powerful. Because for so many folks, they think this is their the sentence they've been given in life almost, right? Which is so sad. And I like this because I like that there's evidence to it and that there's hope. So on that note, let's wrap it up.
Yeah, thank you.
Okay, thank you. All right, take care.